just to give you a quick biography of myself. So I practiced emergency medicine in Northeast Indiana. I was one of the types that discovered that I was really more interested in the business side of medicine than actual medical practice. So after doing the clinical work in the ER, I went back to school, got an MBA from the University of Michigan. My ER group actually spun out their billing department when they split up, then asked me to come back and run that, which I did for a number of years, then started my own billing company, sold that to Medigain last year, and so then I became Medigain's Chief Medical Officer. Medigain's a revenue cycle management company. And part of what I had done previously, actually, in the company that I'd founded was doing practice management for groups. So we had 5 different groups that I was the outsourced business manager on, anywhere from solo practitioner up to 18 providers. So it gave me a pretty good perspective on the challenges from the business standpoint that a number of groups are facing, and working with groups and trying to identify what are some potential opportunities as well as what are some risks to try to manage to help the groups become more successful. So I think a couple of months ago you had a presentation on the Patient Protection and Affordable Care Act, also sometimes known as Obamacare. Went over more of the details of what's included. I'm not going to go over that. What I'm going to try to do is provide more practical perspective on what are some of the key themes, what are some of the planning issues that I think are going to be important moving forward. And one of the key points is when I talk to physicians across the country, one of the challenges is there's a lot of uncertainty with the Affordable Care Act. There's a lot of complexity. It's up to like 19,000 pages of regulations at this point. So that creates a challenge and creates some inertia where physicians say, well, I just want to wait and see what happens, and then I'll decide if I'm going to change or not. The ACA really was a response by the government to some key underlying pressures, and that is for more accountable care, for improving patient outcomes, and for decreasing costs. And those pressures are going to remain the same regardless of what happens to the Accountable Care Act. And so one of the key points is what I'm trying to provide tonight I think is going to be true regardless of what happens with Obamacare and the ACA. And so the themes that I'm going to present I think are still important and can still provide value for you in your practice. And so as Dr. Fox mentioned, one of the challenges in this environment is maintaining the independence of practices. And so what I'm going to present are some key, hopefully, planning things that you can use, some ideas. I don't want you to get overwhelmed. I'm going to be presenting a lot of data, a lot of information. But my hope is that each of you will be able to come away with 2 or 3 ideas or items that you can take back to your practice and implement and start down the path of how do we adjust our practice to be successful in the future. Learning objectives, I'm not going to go through each of those. You'll see those in the topic slides. Also, it's written in the CME handout. But I thought to get started, there are some quotes that I thought are very relevant to the discussion tonight and what's going on with the Affordable Care Act. The first is by Charles Darwin. It's not the strongest of the species that survives or the most intelligent, but the one most adaptable to change. And I think that's particularly true in this environment, that we're going through significant change. I think the healthcare system's at an inflection point where we've got a number of pressures, as I mentioned before, that are impacting healthcare. And so to be successful in the future, I think physicians are going to need to be willing to adapt to those changes and to do things perhaps a little differently than they may have done them in the past. By Lewis Carroll and Alice in Wonderland, if you don't know where you're going, any road will take you there. The key point here is if you don't know what your destination is, if you don't know where you need your practice to be in 3 years, in 5 years, it's difficult to know if you're on the right road. So in order to be on the right road and determine, are we doing the right planning things that we need to do, we need to know where we're going. And so one of the key points I hope that you take away tonight is, can we do some additional planning for my practice that we can take back and look ahead to how can we be better prepared and better positioned to be successful in the future. Famous quote by Wayne Gretzky, I skate to where the puck is going to be, not to where it has been. So many practices are very successful, and you've been very successful historically. However, in a changing environment, some of those key success factors that have worked well for you in the past may not work as well in the future. So what I'm hoping to provide this evening is, where's the puck going to be? I may not be able to give you a precise location, but hopefully some good general points that you can say, okay, these are some key principles that I need to be able to apply and some planning that I can utilize in my practice so that we can be prepared for the changes that are underway. A journey of 1,000 miles begins with a single step. So as I said, don't get overwhelmed with all the information. You're so busy in your practice right now and just seeing patients. How can I possibly do these other things and run the business? If you can come away with a couple of key ideas, some low-hanging fruit, some things that you can apply to your practice, and then just start one step at a time, that's the way to be successful. And finally, don't shoot the messenger, from William Shakespeare. And the point here is, I may say some things that are not pleasant. I'm not here as an advocate of the government or the Affordable Care Act, what insurance companies do, and so forth. But what I am trying to say, these are changes that are taking place. And so we need to come up with methodologies and ways to deal with these changes so that we can continue to be successful in the future. One of the underlying principles that I think is important is we look at what are some of the challenges that the Affordable Care Act is trying to address. So 1% of the patient population drives about 20% of the spending, 5% of patients drive about 50% of spending. So that's an underpinning of why we're seeing some of the themes that I'm going to be talking about. How do we improve continuity of care, integration of care, how about clinical service lines, population management, identifying high-risk patients and managing them more carefully, care coordinators, and so forth. All of those ideas are really tied to how can we achieve better outcomes and lower costs by better managing where the cost drivers are. Redundancies and fragmentation of care drive up the cost. So with the system the way it is right now, a lot of physicians and physician groups, in a sense, are islands. And yeah, we communicate with each other, and yeah, we work within a system, but by and large, physicians are trained to be independent experts. And that independence has a lot of advantages, but when it comes to improving patient outcomes, we're looking at the whole continuum of care. And that's going to be a team-based approach. And how can we work better as a team, working together with other providers, with the hospitals, perhaps skilled nursing facilities, but other points in the continuum of care to really optimize the patient outcomes that we generate for the cost that it takes to provide those outcomes. And then the final point here is fee-for-service model with third-party payers rewards volume. And so the current system that we have is fee-for-service. The more you do, the more you're paid. Well, in general, obviously there's all the games that payers play with denials and bundling and things like that. But by and large, when you do additional services, you expect to generate additional revenue. In the future, it's all going to be about results. So moving to fee for value, it's what are the results that are generated for the activities that you're doing. So doing more volume, driving up the cost to the system is not really going to drive better revenue. With a lot of the models that are evolving, it's going to be how do we generate better outcomes for patients. So starting with the migration of fee-for-service to fee-for-value. One of the key points is, as I mentioned, fee-for-service is a volume-based system. You do the work, you get paid for it. Whereas fee-for-value is all about how do we improve outcomes, how do we improve quality of care, and how do we try to drive out cost. So value to payers, and the payer could be the patient, it could be a third-party payer, it could be the employer, but value in essence comes down to really two variables, quality and cost. And there's two ways to improve the value. One is, so holding the denominator constant, holding cost constant, we improve the quality. So by having a larger numerator over a constant denominator, we increase the value. The other way is we decrease cost while keeping quality consistent. So there again, drives more value, and the ideal is we increase both quality while we're decreasing cost. All of those things will drive value that the payer is looking for and that we need in the healthcare system. Transparency and accountability are going to be important, and it really comes down to measuring performance. I've never met a physician who doesn't believe that he or she provides high-quality care. In the future, it's going to be, well, prove it. What's the data that shows that you provide high-quality care? And care compared to what? What are the metrics that you're using? And payers are going to have their own metrics. Ideally, we're going to have our own metrics from the specialty societies, clinical pathways, and so forth. So I think there's still a real opportunity for physicians to drive the metrics that are being used. But at the end of the day, there's going to be transparency and there's going to be more accountability for what are the outcomes that are generated for the care that's provided. Payers are concerned with the cost throughout the continuum of care, and so they're not concerned just with the care that you provide in your practice. One of the important data points is physician services are really a small component of the total healthcare spending each year, so throughout the United States. However, physician decisions drive a very large portion of the total cost in the system. So the decisions that physicians make and the choices that we make as physicians are very important to the total cost of the system. And so that's why payers are looking at how can we achieve better cost overall, for the quality of outcomes that are generated throughout the whole system, not just for individual physicians. So again, it's that team-based approach, it's integrated, coordinated care, whatever you want to call it. So some of the key impacts, as we look forward, we're seeing new reimbursement models, and I'll talk about some of those in a moment. And with these new reimbursement models, they're designed around the whole concept of fee for value, generating better outcomes for a lower cost. One of the key challenges is going to be the payers are going to be defining this. As I'll show in a moment, United Healthcare has theirs, Medicare has theirs, Aetna has theirs. So it's going to increase the complexity of the system because each payer is going to have their own metrics, incentives, disincentives, what are the metrics that they track, and so that's going to increase complexity. And so I'm a big advocate of IPAs like PPN because I believe they provide a significant value add by providing the infrastructure that can help small and mid-sized groups to adapt to these types of changes and provide the infrastructure and the expertise that is difficult to provide on your own. And that's where I think PPN has done a very good job in the past of doing these types of things, and that moving forward in the future will have a very important role in being able to provide services and provide structure that groups will have a difficult time duplicating on their own. There's going to be a linkage between financial performance and clinical performance. So when we go into an outcomes-based or quality-based system, you need to make sure that you have an ability to link up what's the payment we receive from the payer. Are they in fact following through? So if they say they're going to reward certain metrics, if I met those metrics, I want to make sure I get that reward. And at the same time, I want to make sure that I'm not getting penalties when in fact I shouldn't get penalties. So you're going to have good data tracking. We're going to talk about some of the information technology needs in the future. Risk shifting is going to be an important issue. Right now, most of the risk is on the payers. So they have all the actuaries on their staff that look at based on patients and risk factors and diseases and conditions and so forth, how they rate those patients and charge them premiums accordingly. The payers are going to start trying to shift that over to the providers. So when there's population management, as providers, we're going to need to know what are the risk factors of the patients in our population. So do we have some actuarial capabilities so that we can start ranking what are the risks, who are the risk patients, who are the high risk patients, and how can we better manage that? Because if we're going to have evaluation on our performance, we need to know what's the baseline, what's our risk stratification currently, and then how can we drive that lower as we measure it and try to do the strategies to change that. So there again, that's where I think having an infrastructure that a PPN can provide is important to groups. And then we've already talked about the increased complexity. So payer contracting in the future is going to be even more difficult than it is right now because it's not only about looking at what are the payments we're going to receive, but it's going to be what are the metrics? Are they the right metrics? Who chooses the metrics? If I believe that this payer's is inappropriate compared to other payers, you need to be able to understand that, know the patient population that they're going to try to bring your way, make sure that if they steer more patients, you understand what are the risk profiles of those patients, because a lot of it's going to be driven by what are the outcomes, what are the results that are going to be generated. So we really need to have that good understanding of what's our patient population. Some strategies to improve quality of care, really boil down to 3 items. The first one is standardizing care. And so the issue here is how can we diminish variation? When I talk to a lot of physicians, a lot of how we practice medicine depends on where we trained, the area that we're in, personal experience. If we have a bad outcome with a particular patient, oftentimes that will influence how we treat other patients. And so there's a fair amount of variation. Even though we have some evidence that there are best practices, there are clinical pathways that generally provide better outcomes, the number of physicians that follow those, it's not as consistent as we would hope and expect. So that's where there's going to be an initiative in the future to really provide more standardization of care through clinical pathways, through clinical service lines, and things that lend themselves that when we have like conditions, like diseases, like patients, ideally they're treated in a like manner. Now those clinical pathways need to have the flexibility that you can step outside of it when appropriate. But the whole point is we want variation that's based on evidence. When do we need to step outside of the clinical pathway? And we don't step outside it unless there's a clear evidence-based reason to do that. Versus we're doing it because, well, that's the way I train and that's the way I practice and so be it. So identifying what are some of those standardizations that we can start employing to decrease the variation both within our personal practice and with our group practice, even within the network for like the PPN network, all of those things will be important themes moving forward. Identifying how we can facilitate better coordination of care. So once again, it's at the whole continuum of care, and what's real important here is going to be the communication. How do we make sure we're communicating with other providers so that it's not just me doing my part in the patient's care, But I'm also concerned about how are other providers that the patient's seeing providing their care? What can I communicate to them that would help for wellness, preventive care, helping the patient make healthy choices, helping other providers make good choices that are consistent with the care plan and with the clinical pathway that we're trying to follow. Being able to have the data and analyze the data is going to be extremely important. And so, when I start talking about, some of the information technology capabilities in the future, in order to make good decisions, we need to have data. And so we've heard, some of you may have heard the concept of big data. Other industries are moving that way. Certainly healthcare is. It's all about having the data, having the metrics, and being able to measure performance and then learn from that. If we're not doing well, why not? How can we do better? If we are doing well, we want to make sure that we showcase that and that we ideally get rewarded for that and paid for that. Required capabilities in a value-based payment system. The key is to drive out cost and to create value. And so one of the take-home points that I hope you come away with, each of you works very hard each day to take good care of your patients and to provide good patient outcomes. But being successful in the future is also going to be, how can I create more value? How can I create value that I can share in as a provider, but also creates value for the patient through the better outcomes, creates value for the payers through decreased cost, and also for partners. So working with the hospitals and perhaps other clinical resources within the continuum of care. All of those are going to be important, but it really starts with the physician, because the physician's in the best position to determine what's in the best interest of the patient, how can we help drive up better clinical outcomes for the patient, and how can I be a part of that, and whether it's designing clinical pathways, helping design better continuum of care, communication pathways, working within the network, working with other groups that I can partner with for particular conditions and so forth. Those are all things that can generate value and ideally generate additional revenue in the future. Care strategies for chronically ill patients, that's a key component of it. We know that certain conditions, heart conditions, diabetes, joint conditions, cancer, all very costly diseases. The chronic conditions, very costly. And so these are going to be some of the key diseases, conditions that the healthcare system is going to look at. How can we achieve better outcomes for a lower cost? And so if you can look within your practice, whether it's through clinical pathways and so forth, how can we be a part of that? How can we create better care for chronic patients that we see in our practice or working with other providers in our network? All of those things will help generate value. Protocols for the high cost and frequent episodes. So when we can identify who are those high risk and very high risk patients, and how do we move from a reactive to proactive. So rather than treating exacerbations as they keep occurring and the patients keep getting sick and getting admitted to the hospital and taking a lot of resources to care for them, how can we get a lot more aggressive in our preventive care and in our managing wellness and in helping engage the patients so they make healthy choices? All of those types of things to try to keep the patient out of the hospital rather than managing when they're in the hospital. Helping the patient to stay healthy rather than treating the recurrent exacerbations. Care coordinators, sometimes case managers, navigators, care coordinators, they go by a number of different terms. I look at them as project managers. So when you have these high-risk patients, when you have a lot of these chronic diseases, they tend to be complicated. They're seeing multiple providers within the continuum of care. You need somebody that helps manage that. Physicians are very busy, so whether you have them within the practice or within the IPA or otherwise, having someone who can provide that care coordination, making sure that the trains run on time, the patient's at the right place at the right time to get their care, the right information is in the provider's hands when they see the patient, all those things are going to be important. Patient communication tools, we'll talk about some of the patient engagement strategies and tools that are out there. But then finally also looking at what are the value-based incentives within the practice. As I mentioned earlier, value-based reimbursement is a team sport. So it's really a team within your practice as well as within other provider groups. So what are you doing within your practice so that all of the staff have the same goals and have the same incentives, have the same drive for high performance? The front desk staff, your nursing staff, your medical assistants, any non-physician providers, PAs, NPs, we want everybody to have the same goal and everybody's working together to how can we create better outcomes for a lower cost. And so ideally you want to make sure everybody's on the same page, everybody's pulling the wagon in the same direction. And how do we make sure that everybody's aligned, that they understand the goals, that they understand how we're being evaluated, creating value? Because ideally, the value is really going to be driven by the staff. They're going to be coming up with the good ideas. Here's an opportunity. they're going to be the ones that tell you, remember Mr. Jones is coming in this afternoon, he always does this and he has these recurrent episodes. So they're the ones helping to make sure systemically, how do we provide better care? What are some of the things that we can do to manage it? So the drive for better coordinated and integrated care, as I mentioned earlier, it's how can we decrease the unwarranted variation in care? Compliance with clinical pathways, so it starts with measuring it. So if we identify what is the best practice, what's the clinical pathway for a particular disease or condition or high-risk patient population, and then we need to be able to measure the compliance. So at the provider level, so for each individual, at the practice level, how are we doing as a practice, and ideally then within the network as well. So that ideally what we're doing is we're generating the better outcomes through better coordinated care. We have less variation, and then that's something that we can get rewarded for. Ensuring effective handoffs. When I worked in the emergency department, one of the high-risk areas for malpractice is always that patient handoff. When you have that change of shifts, and so physician A is handing off to physician B. When physician B assumes physician A did something, physician A is assuming physician B did it, and no one ends up doing it. Those are the risky situations, and it's the same thing in the continuum of care. Whenever we have patients going from one provider to another, when they're discharged from the hospital and who's following up, making sure there's good communication, everybody's on the same page, what needs to happen to keep this patient from bouncing back into the hospital or needing more resource utilization or bouncing back to the emergency department. All of those things are really going to require good coordination, good integration of care, and good strategies for doing that. And so again, that's really going to come down to what are the communication tools, what are the technologies that we can employ to achieve the better results. So when we look at value creation, at the end of the day, there's really four key strategies to do that. It's measuring value, creating value, how do we package and price that value, and then also how can we become organized for value. So when we're measuring value, one of the first things we need to do is we need to start with what do payers want? What do patients want? What is value in their minds? Our partners, for the hospital, what does the hospital consider value? So we understand what's going to be important to them, because ideally those are the types of metrics we want to use. A lot of this is going to be specialty specific and practice specific. So depending on your type of practice, if you're a surgeon or an anesthesiologist, on-time operating room availability may be important. It's generally pretty important to the hospital because those operating rooms are high-value resources, and if they're waiting around for the anesthesiologist or the surgeon to come there, staff aren't being able to do any productive work. The operating room is not producing results, patient care, and so forth. So, fidelity to making sure we stay within the benchmark parameters and expectations for on-time availability could be perhaps an important parameter to measure. Patient functional improvements. If you're a pulmonologist, pulmonary function tests. For the diabetics, HbA1cs. And so for different diseases and conditions, there are some of the key function objective metrics that we want to be able to measure and ideally follow over time. A lot of the electronic medical record systems do that, but we want to see how is it trending over time. Ideally, it's getting better. If it's not, why not? What can we do to change that? If it is getting better, we want to make sure that we keep doing that and continuously improve on how do we keep that trend going in the direction that we want it to. Reducing unwarranted resource utilization. Sometimes because we don't have systems that can communicate, we're repeating tests. We're repeating lab tests, imaging studies, and so forth because, well, the patient came in today and I don't have the chest x-ray that she did yesterday at the hospital or at another group, so let's just go ahead and repeat it. From the system standpoint, that's an unnecessary additional service. So how can we drive that down so that if there was an imaging study or a lab test or something that was done recently enough that fits our purpose, we have access to that rather than we have to repeat it and then again we're providing extra cost. Reducing unwarranted, making sure patients adhere to their treatment plans. There's data out there that shows when patients walk out of the physician office, they remember very little of what they were told. So if you give them a new prescription, they'll probably remember, okay, doc said I need to take this new drug, and doc said to stop the other drug. But all those instructions that you carefully told them, if it wasn't written down, good chances they're going to forget a lot of that. And so what are the things that we're doing that we hand the patient when they leave the practice that's written in layman's terms that helps them comply with the plan of care that we have for them? There may be patient education handouts that we can give them, but also making sure they're aware of what are the care plans, what are your goals, what are the expectations. If weight loss is one of the key things that we're trying to do with a diabetic patient, we may establish a goal. We want you to lose 10 pounds before you come in for your visit next month. And here are the 3 things we want you to do. You're going to need to talk to the dietitian, you need to do this. but really making sure that that patient is engaged and understands what they need to do, what are the healthy choices they need to make to have better outcomes. And then also the adherence to the clinical rule sets. So once we identify what are the things that we want to do, if it's vaccinations for pediatrics groups, diabetic care, and so forth, we're making sure that we're getting up in that 90 percentile adherence to those ideally, unless again there's a warranted reason to step outside. Collaborative approach to continuous performance improvement is a key part of creating value. And it's starting with the evidence-based guidelines, reducing or eliminating avoidable costs. Some of the things, lower cost substitutes. I work with a group of urologists up in Northeast Indiana, and a couple of years ago we were in a board meeting and discovered they had 4 different types of Foley catheters that they were using, 4 different types of catheters. And came down to one as well, and there's a certain type of patient, and I like to have this one available. And then other people were using it. Well, it was a high cost one. Groups still being reimbursed the same amount when they did the procedure, but they were using a higher cost catheter. Came to be that there was an acceptable standard where everybody said, we can all live with this one Foley that's really at the best price point, has the quality, and we only step outside of that. We have one specialized catheter that we use for certain conditions. Helped increase the profitability of the group, and really was just having that dynamic of there is a lower cost supply or a lower cost vendor that we can use that still meets the quality requirements that we need, but still saves money for ourselves or for the system. We've already talked about reducing the total cost for the high-risk patients. Packaging and pricing value. So here's, again, another opportunity that I think where PPN provides significant value and can continue to provide value going into the future. How can we package the value? So we have the member physicians, the member practices of the PPN. How can we develop acute and chronic care payment bundles that perhaps we offer to payers? I don't know if you saw it last week in the Wall Street Journal. There was a editorial written by a general surgeon, and it was interesting from a couple of standpoints. And so this was a general surgeon that described a patient that he had for an inguinal hernia repair. And the patient had one of the old style indemnity insurance plans that didn't have a required provider network that he had to use and so forth. And so the patient went to the hospital on the day of the surgery, and the hospital looked at his plan and said, well, it looks like the plan's going to pay $3,000. Your total hospital cost is $23,000. We'd like you to give us a check for $20,000. And the patient said, I can't afford that, so they canceled the surgery. Went back to the general surgeon, and he said, well, because you have this indemnity plan, you don't have to use it. Let's do this as a self-pay. And I'll be happy if you pay me up front this amount of money. He worked it out with the anesthesiologist that he would be happy, or she would be happy if she was paid this amount of money. Got the hospital, a different hospital, to accept a fixed upfront payment. And so for a total of about $3,000, that patient had a package service, anesthesiologist, surgeon, and hospital care, and they saved $17,000. So it's that whole concept of can we package services and create value where everybody benefits, and offer that to payers, perhaps offer that to employers, but really thinking about how can we generate value for ourselves, getting more business, but also providing value for the patients. Disease management programs, are there particular diseases, and it really comes down to specialty specific. And in primary care, depending again on what are the diabetes cares, your hypertension, you can set up clinics, you can set up different pathways to try to say, how can we perhaps aggregate these clinics, aggregate these patients? Maybe I see all of the diabetics, or try to see all of them, every other Friday afternoon. Then we can create workflows, we can create pathways, we can create protocols really designed for those patients with this particular disease to make sure they're seeing the ophthalmologist, that they're doing all the things that they need to do to have the best outcomes. Population health management, health coaches. Health coaches are something that's interesting. I work with a software company providing some advisory input to them, and they're a wellness software. And so their whole concept is they provide wellness as a software for insurance companies to share with the patients to try to get those patients to make healthier choices, diet, exercise, smoking cessation, alcohol use cessation, if they're using too much, those types of things. But a key part of that is health coaches. So they also connect the patient with health coaches, because what their data has shown is when the patient has a coach that they can ask questions to, that provides encouragement, are you following up on these things? It helps provide adherence to the care plan and helps provide better outcomes. And then also it gets to the whole point of personalized care plans. So if we can come up with a care plan and we can really personalize it to each individual patient based on their risk factors, based on their family circumstances, involving family members and so forth, we can get better outcomes, and we should be able to share in the value created by that. Organizing for value, so some of the things that I think PPN is already doing, deliver cross-continuum care. How can we prevent unnecessary emergency department visits, hospital admissions, the packaging the services within the network, being able to potentially go directly to employers. So can we take, perhaps it's employers that have their own insurance plans, so they self-insure. We can go to them. A lot of employers, that's actually a strategy that I'm seeing with a lot of employers. The large employers are now employing their own physicians. They have their own clinics. It's all about keeping their patients well. Well, maybe we can do that. Through the network or through our practice, we can go to employers, offer additional services or offer a package of services and get revenue, whether it's a co-management agreement or gain sharing or some way that we can share on that. Same thing with the hospital. As we'll talk about in a few minutes, clinical service lines are a hot topic with a lot of hospitals. It really depends on physician leadership. What are the things that we can do to engage the hospital or to engage other providers in the continuum of care to help direct, what are the best practices, what are the clinical pathways that they should be following. So some of the new reimbursement models, and this is from United Healthcare. United Healthcare is the largest health insurance company in the United States. So this was a surprise to me when I saw this data. They already have or claim to have 575 hospitals and over 75,000 physicians in accountable care organizations. So this is not futuristic. We hear what's happening with Medicare. We hear about accountable care organizations. UHC says, we've got 75,000 physicians in different areas of the country that are already participating in accountable care organizations. It's already here and we're going to grow it. Patient-centered medical homes, according to UHC, they have a 2-to-1 return on investment. For every $1 they spend on patient-centered medical homes, they generate $2 of cost savings. So I think we can expect to see more patient-centered medical home promotion by United Healthcare and possibly other payers as they start seeing this model as generating value, generating improved outcomes, coordination of care, and so forth. Payment bundling. One of the things that they do is they have a pilot study on bundling chemotherapy payments. So they're bundling it together with the oncologist services into one payment bundle. Creating centers of excellence. These are things like for transplantation services that may need to go to a specialized center. But perhaps there's some regional opportunities that you can do right here in coordination with the medical center or with your practice or with PPN that you can create a regional center of excellence for particular diseases or conditions and so forth. And then being able to, they're looking at different physician gain sharing and capitation models. For Medicare, I think we're all familiar with the PQRS, Physician Quality Reporting System. Medicare tends to lead the way and a lot of other payers tend to follow. So this is that whole incentive, disincentive. So we know the reporting metrics, there's 150 some odd depending on the specialty that you're in. They started off with about a 2% payment incentive. It's now down to 0.5% this year. In 2015, it's switching over to a penalty. So they're trying to get physicians to start recording these metrics and recording this data on what they're considering to be quality, and they're rewarding it initially, and then it's changing to a disincentive. This is the type of model that I expect other payers will be doing. Accountable care organizations. So Medicare's had a number of pilot studies. Some of them haven't done so well. You've read about some of those, and hospitals aren't signing back up again. But they're testing out different models. It's all about how can we generate better outcomes and generate cost savings. Patient-centered medical homes, they also have specialist care models. The urology practice that I mentioned earlier is in the process of developing a urology, patient-centered medical home and a men's health strategy. So it's not just primary care, but specialty practices can also look at how can we become involved in this, either through the primary care patient-centered medical home or perhaps through our own specialty-driven patient-centered medical home. And then finally, hospital value-based purchasing programs. So I think it's receiving a fair amount of attention now that hospitals are getting penalties if the patient bounces back within 30 days. So they're really trying to make sure that they manage that post-discharge care well so that patient doesn't come back. That's really going to depend a lot on physicians, making sure that we have good communication, we really have treatment plans that we're aggressively working on that patient on follow-up so that they don't go back into another exacerbation and bounce back to the hospital.